So a very warm welcome to everybody joining us for this ICMLF CML highlights of the recent European Hematology Association conference that was held in Madrid in June. We are absolutely delighted to have Professor Andreas Hochhaus and Professor Nick Cross giving their CML highlights of the meeting. It was a very strong CML program with a lot of content. So we will dive straight in. So as I mentioned, today we are very happy to have both Professor Andreas Hochhaus and Professor Nick Cross. Professor Hochhaus will be giving us the clinical highlights today. And just a brief introduction for Andreas. Professor Hochhaus is the Director of the Department of Hematology and Medical Oncology, Coordinator of the University Tumor Center, and co-director of the Comprehensive Cancer Center Central Germany at Jena University Hospital in Germany. He is full professor for internal medicine, hematology, and oncology at the Friedrich Schiller University in Jena. As co-chair of the German CML Alliance, Andreas Hochhaus is also focused on enhancing access to clinical trials for all patients and driving patient participation. Dr. Hochhaus has published 680 peer-reviewed papers and is co-editor-in-chief of Leukemia. So with that introduction, I would like to welcome Andreas. Please share your slides and we will begin with the clinical highlights of EHA.
Yeah, thank you very much, Nicola. Dear colleagues, I would like to highlight a few abstracts only from EHA. It's impossible to do everything in 15 minutes. What are my clinical highlights of EHA? First, I would focus on the treatment goals, what we want to achieve and in which stage we want to switch. We had a discussion on that in the Hematology in Focus session. The red signs show the established criteria. Of course, in case of lack of response with cytopenias, loss of response with mutations or without mutations, and of course, in grade 3 and 4 intolerance, we need to change treatment. But there are other criteria which are not yet established, like lack of deep molecular response for each patients aiming at TFR. Personally, I'd like to change, and I will change treatment in this situation, but it's not generally recommended and not generally established by the people who give us the money for the patients, the insurance companies. And of course, we need to optimize quality of life. That's now the major criterion for CML management, to have a normal quality of life during treatment. And we want to prevent major adverse events when the given treatment has a specific risk for later problem. And I think these are all now criteria for me to change treatment. And we have in the registration criteria different lines of treatment. 4 drugs are registered for first line and a few are registered for third line. There is an in-between. I don't care about that. I don't see the lines anymore. And I recommend to avoid lines, to go more for the biology of the disease and look at the specific grading of intolerance, to look at the specific resistance profile, and to select the drug which is most likely favorable for this specific situation. And but the lines are still in the package inserts and are still in the label, but we should focus more on biology. I would like to focus on 4 abstracts. One is the Ask for First study, Asciminib first line. One is the DasaHit trial, Dasatinib dose optimization trial, the OPTIC trial, which focuses on Ponatinib dose optimization, and a combination trial and a phase 1 trial, Ponatinib and azacytidine in myeloid blast crisis. First, Ask for First. The study is the registration trial for Asciminib in first line. Asciminib was used with 80 milligrams per day. There was a stratification according to the doctors' and patients' choice what would have been the standard of care in this specific patient. And this was selected as the comparator arm in a one-to-one randomization. And the other stratification criteria is the ELTS risk category. Therefore, we compared Imatinib as a first-generation TKI versus Asciminib, and in the other stratum, second-generation drugs versus Asciminib, with the endpoint MMR at week 48 for Asciminib versus all the standard TKIs, and Asciminib versus the Imatinib treatment. The criteria between Asciminib and all the drugs were very well balanced, same age, same risk score. But when you look at the follow-up of after 16 months of follow-up, 13% of the Asciminib treated patients have discontinued, but almost 30% of the comparator arm. That means Asciminib was more efficacious and better tolerated, therefore maintained in more patients. This is the major endpoint, Asciminib versus all investigator-selected TKIs, 67 versus 49% MMR rate at week 48. And this is the cumulative response. Here you see with Asciminib, we started week 12 to achieve MMR, which was very rarely the case with the ATP competing drugs. But also EMR, early molecular response, and the deep molecular responses at 48 weeks were favorable for Asciminib versus investigator-selected TKIs. Second primary endpoint was Asciminib versus Imatinib. The difference is even larger here, 69% MMR with Asciminib, 40% with Imatinib. And you see here with Imatinib, almost nobody got an MMR at week 12, but more than 30% with Asciminib. That means we have a faster response with the Asciminib, the specific BCR-ABL inhibitor. Also, EMR, MR4, and MR4.5 are favorable with Asciminib, of course, as expected, because Imatinib is less active compared to the second-generation drugs. Therefore, we expected a bigger difference here. Which patients should be treated with Asciminib? Actually, in the subgroup analysis, all criteria are positive or favorable for Asciminib, all ELTS strata, both genders and all age categories. When we now focus on the side effects, we see less grade 3 and 4 side effects with Asciminib. We see 4.5% patients who discontinued on treatment versus 11 and 9.8 with the other drugs. And the dose adjustment was, of course, regulated by the protocol. 30% of patients needed a dose adjustment. This is smaller, this number, than with Imatinib in second generation. All in all, Asciminib showed a favorable safety profile as expected because it's BCR-ABL specific, and on the other hand, a higher efficacy after 48 weeks of treatment. It could be developed as a new first-line option, could be the standard of care for first-line, but of course there is the price discussion ongoing. Any new drug is more expensive than the old drugs, and therefore the discussion is ongoing for which patient should we use Asciminib. But I hope it will be registered soon in a lot of countries worldwide to get access to this drug, which is definitely better tolerated than all the others. So, second abstract, Dasatinib, dose optimization. We know that we observe in about 20% of patients pleural effusions with 100 milligram Dasatinib per day. Therefore, a lot of studies ongoing to optimize this. In the US, the colleagues from MD Anderson did a study with the dose halving. That means 50 milligrams per day with good efficacy results and good tolerability, but unfortunately not a non-inferiority design. We had a different approach here. We compare 7 days versus 5 days because of the short half-life of Dasatinib and the importance of the peak level and not the trough level of this drug. And we expected with 2 days holiday per week, that means on the weekend, a reduction of the side effects because pending imminent side effects may go away with 2 days break. This was randomized for first line and later lines of therapies. The first endpoint was, of course, MMR for the non-inferiority design, and this was met. That means the MMR with 7 days was 81% after 24 months, with 5 days, 78%. This is not different statistically, and our hypothesis was met here. That means it was a positive efficacy study, but not for second-line treatment. Patients for second-line, we had a favorable MMR rate with 7 days versus 5 days, but in first line here we had the same parameters. The picture is not here. This is not the first line. The third line is identical, but this is the first AE of interest. When we look at all adverse events, they are similar. When we focus on pleural and pericardial effusions, we see a major advantage for the 5-day schedule. Here is the comparison of the pleural effusions and pericardial effusions, the incidence of 5 days versus 7 days. You see halving of the incidence of effusions, 8% versus 16% with the 5-day schedules. Our conclusion is that with 5 days per week in first line, we achieve the same efficacy, but less as pleural and pericardial effusions. All other side effects are similar. Therefore, the 5-day schedule in first line could be established as a new standard of care for patients with chronic phase CML. For second line, we would continue with the 7-day schedule of Dasatinib. Third abstract is the update of OPTIC, dose optimization of Ponatinib. 4-year results was presented by Jena Apperley. OPTIC was needed because of this 45 milligrams Ponatinib, more than 20% of patients had major cardiovascular problems, and therefore the FDA and the EMA asked for a dose reduction after response, and this should have been tested in a study, in a prospective study. This was a randomized study between 45 starting dose, 30 and 15 starting dose in patients with 315 mutations or patients with more or at least 2 prior tyrosine kinase inhibitors. You see on the left that patients with 315 mutations and a major advantage of the 45 milligram dose. The colleagues were asked to reduce the dose after the achievement of the 1% BCR-ABL level. This was done in this study, but even with this dose reduction, the starting dose with 45 had a major advantage. This is not the case, not very different with mutations outside of 315, but also in patients without BCR-ABL mutations. However, all in all, the incidence of the cardiovascular side effects was reduced with the approach to reduce the dose after achievement of the 1% BCR-ABL level, only 8% versus historically more than 20% major cardiovascular side effects in this cohort. My last abstract was presented by Dr. Rousselot from Versailles, and that's a phase 1 study also on Ponatinib, but now in advanced disease. That means late chronic phase, accelerated phase, and blast crisis. Ponatinib was here combined with azacytidine as an epigenetic active drug in a in a very well-designed way, starting dose 45 milligrams as an induction, then dose reduction in case of hematologic response to 30, and then to 15 milligrams Ponatinib, and a fixed dose of azacytidine 7 days per month in addition. These are the cohorts: 7 patients with chronic phase, 2 with accelerated phase, 10 with myeloid blast crisis. The blast crisis patients and also the late chronic phase and accelerated phase patients with additional chromosomal aberrations in most patients. And we see here the side effect profile. Of course, there was, as expected, a neutropenia and a reduction of the platelets. However, this was not that advanced. That means when we compare this to high-dose chemotherapy, as it used to be the standard for blast crisis patients, we see a major improvement here with less morbidity on this treatment. The response is, of course, biased because the good responders received more cycles. But if you look at these patients who received more than 2 or 3 cycles, then you see a gradual reduction of the BCR-ABL level. But I think that's not the most important point. The most important point is the achievement of a hematologic response, which was achieved in 79% of these patients. And this was, of course, a very good preparation for allogeneic stem cell transplantation, and patients who were transplanted on the lower right here, 100% of these patients survived. And when you look at the major root additional chromosomal aberrations, of course, patients without major root aberrations had a better survival. However, I think it's a reasonable or even a good approach for treatment of myeloid blast crisis patients when high-dose chemotherapy is not an option for comorbid patients, for instance. And I'm not sure if all patients need high-dose chemotherapy. When we achieve elimination of the blasts with TKIs alone, then I think we have a good preparation for allotransplant, and we need to transplant all patients in blast crisis who are eligible. Therefore, I think with the dose of a chemotherapy, we should be cautious and should titrate what is eventually needed. These were my 4 abstracts which I selected. Of course, I'm open for any questions also for other topics and other abstracts from EHA. Thank you very much.
Thank you, Andreas.